Hi, this is the recorded lecture for HSC 400 Healthcare Analytics. And we're going to look in this particular lecture at Chapter 8. What we're going to look at is leveraging analytics and quality improvement activities. And if you look at the Trevor Strome book, you'll see that he really pushes that quite a bit. And I really strongly agree with that. I think that those two pieces in a healthcare organization really are integrated or basket woven together, and they create a much stronger entity when they're interwoven in such a way. So it's important to really look at that information, or look at that organization. We're going to look at introduction here. The data and information is not sufficient to achieve transformation in healthcare. If you have the data but you don't act on it, it's kind of a waste of time. I give you the idea that you come to a decision based on data, and maybe your CEO has a gut reaction a different way, and you don't do it, then it was a waste of all that analysis. Data analytics, quality improvement, process improvements was work in a team collaboratively and functionally to achieve maximum success. I can't even begin to stress that enough. All these have to be really a very collaborative group. You can't have like the data people, and the analytics people, the QI people, and PI people all working separately. It creates animosity. It creates a demand for resources that are competitive. It does all sorts of terrible things. So you want them to be able to work together. And analytics has to be leveraged to provide the foundation for quality improvement and process improvement projects. So you get the best effort with the least amount of expense. Now, moving from analytics insight to healthcare improvement, when used in concert with quality improvement, that's PDSA and Lean and Six Sigma and all the others, analytics helps to identify the most significant issues for the HCO. And I want to really stress that, doing a quality improvement project that doesn't gain you much isn't really helpful. Doing a quality improvement project that gains you a lot is really important. So you want to gain the maximum value in your project. So to gain maximum value from analytics, QI projects need to do the following. They need to retrieve and analyze base data to document current performance and our quality measures against which to compare future performance. That's a real problem in lots of places. They start a project, they don't know where they started from. So they have no idea what their improvement is. So the first step is to do the work and identify where things are at now as aggressively as you're going to analyze them when you make the improvement. Sometimes they'll take sort of a random measurement and say, okay, they're bad. They will do these things and they get a little better. And sometimes what they didn't improve at all, didn't make any change whatsoever. In fact, they just altered the course without making any major change. So you have to collect data as aggressively for the baseline as you're going to collect it during the project and after the project. You have to utilize or develop well-defined performance indicators that accurately reflect the processes, the procedures, the policies, or the treatments that you're going to change. And I love this last one because it's important. People will make changes and then they leave it alone. They go away. And then the people go back to doing what they were doing before. So perform ongoing evaluation and reporting of relevant performance indicators to quantify the impact of implement changes and to identify further revisions as necessary. This sort of puts people on notice that you're going to keep measuring what they're doing and you're going to follow it so they can't revert back. I've always said that when you make a change, you have to make it impossible or painful for people to revert back to what they did before, or it will never stick. It will never be sustainable. These are the phases of a project. There's 5 quality improvement phases. You have to define the problem, you identify your opportunities, you execute improvement activities, you evaluate your outcomes, and you sustain those changes. And then ultimately you get a successful and sustained improvement. I can't emphasize how these last are so much more, or as important as the first 3. Now, analytics is important in almost every phase of healthcare quality improvement, or PI. Analytics needs for quality initiatives depend on the phase of the initiative, who is using analytics, what information or insight is required, and of course how that insight information is going to be used. All of that is a really important piece of this as you go forward. Now, ranking of quality improvement projects, clinical, financial, or regulatory. Clinical is usually the most important reason to undertake a quality improvement project because it directly impacts the patient's quality of care and ultimately their satisfaction. It reduces adverse outcomes, which again improves the patient satisfaction and all of that. And by the way, adverse outcomes cost the organization more money. When most insurance companies and even Medicare and Medicaid only pay based on a disease. So if you have appendicitis, they'll pay you X number of dollars to take the appendix out. They won't pay you for the post-op infection that you got because you were careless until all those days are free to them, and they take the money comes out of your revenue. Not good. The second one is financial. A priority when selecting improvement initiatives or process improvement. Focuses on financial health and the healthcare organization. It helps reduce inefficiencies and what are called non-value added steps. Remember, non-value means we do these steps and they don't help us at all. We add these steps to this process in hopes of making it better. We just make it worse and more cumbersome. And then regulatory and legislative areas of priority to meet requirements could result in dollars saved or at least not lost due to decreased reimbursement. For instance, if CMS, Centers for Medicare and Medicaid, if you are not meeting the standard level, quality level, and you don't initiate a quality improvement project to help make it better, they will start to deduct their reimbursement percentage from you, up to 4%, as a matter of fact. Now, 4% doesn't sound like much, but in the world of a large medical center, it's millions of dollars a year. So it sort of helps you to make some decisions that are more positive. Analytics in the problem definition stage, it's important consideration in this step are, what are the goals and objectives to which the problem relates? In other words, what are the relevant indicators and metrics that are going to be used? You're deciding how you're going to do this. What baseline data is available and what data will be available moving forward for monitoring and evaluation. So I always say that you should be as aggressive with your getting your baseline data as you are for monitoring and evaluation, and that's not what happens sometimes. I have made some quality improvement groups very angry because when they got through, I said, well, you have nothing to show that you did any improvement. Well, it got a lot better. Really? What was your baseline data? And they showed a sort of a slipshod baseline data. I said, you have no idea what that was. I said, now, you can go back and redo that data and then prove that. Well, we've already done the project. No, you're not. You didn't do the baseline data. And I would have you show the baseline data. We'd start to analyze baseline data against the change in improvement, the sustained improvement. We either find that maybe their improvement was greater than what they thought, or maybe there was no improvement at all. And so they started to get the idea that if they started to do projects and they didn't do the baseline work, then I wasn't going to improve them. And I would make you go back and do it again anyway. So they started to get the idea that that was an important step, and it is an important step. Now, the first step is to, in the definition stage, is to quantify and measure the magnitude of the problem. That's that baseline data thing. Should relate to the strategic quality and our tactical level performance improvement objectives of the health organization. So in other words, we should quantify that, but it should have some relevance to our strategic plan or strategic performance improvement objectives. And again, it should support the strategic plan. You'll hear me say that a million times, because if it doesn't, I have to ask you why you're doing it. Information gathering in the benchmarking phase of this, QI members obtain data regarding the issue. They define the indicators and metrics, if you will, and the baseline data is established for the healthcare organization as it applies to that project. This is an important step that, like I said, often gets overlooked or is sort of put out there in a slipshod sort of way. Baseline data should be a true measure of existing performance that you consider. The data source should be the same as used for the ongoing measure and evaluation. Data quality should be as high as possible prior to performing any analysis or comparisons, and the data quality of the baseline should be equal to the data quality of the evaluations later. The time period must cover a long enough time to be an accurate reflection of performance and must be relevant and as current as possible. Now, those don't sound like they go together, but they are. For instance, if you have a process that's out of whack, you should look at what it's been doing in the last year, what it's been doing in the last month, and then start to trend the day-to-day and see what's going on. That's when you start looking at time periods, so you can start to see where things are at. And it may even help you focus on where to do the quality improvement project at, what places need to be improved first. And you have to define indicators. Those are comparisons with baseline data. They're analyzed and reported using the same indicators that will be used for monitoring and evaluation. Your baseline indicators have to be the same indicators you're using for monitoring and evaluation, or you have nothing. Data used for baseline should be reliable. It should be trusted as true measure of performance. If no data is available, you have to obtain it manually, and that is a painful process. So having electronic medical records and electronic tracking system is very, very helpful. And if you don't have that, doing it manually is painful and costly and expensive and time-consuming. So when reporting baseline data, one important consideration is how to aggregate that data together. How do you put it together and have meaningful information? I always call data that gives you very specific information, and then some that's homogenized. That homogenized means they mix it all together, and what you get out is like an average of everything. It doesn't really tell you the variations within the the data sample. And homogenized information is usually not as helpful as specific indicator information. So for instance, if I said, okay, how many people, or what is the waiting period in the emergency room? Well, it's all homogenized, averaged, if you will. And it says, oh, it's only 4 hours. Hey, that's not so bad. That's not so bad, except we have, 50% of the people that are waiting 20 hours and 22% of people waiting 30 minutes. That's bad. That's a bad problem. So aggregating information or homogenizing information has, and I say aggregating, is putting it together but not homogenizing it, which is kind of an important critical point. Now, when you look at the definition stage, there's baseline. We establish a baseline for this data, this change in performance when aggregating differently. So we see this homogenized baseline length of stay here, aggregation by the month. We see the baseline length of stay aggregation by the week. Now we see this aggregation of the same data, but this is weekly reporting. This is monthly reporting. Now look what happens here. We're starting to see some very interesting things. We see certain parts of each month have these points in them. And so this would suggest it's all nice and even, and this suggests not quite so even. And the truth may be that we're seeing some weeks that are more difficult than others within a given month. And so then you have to start saying, well, is that really helpful? Do we need to start looking at days of the week? And if the days of the week are significant, then you may have to start changing your staff based on that. So you have to drill down to the point where the information is useful. This is homogenized data. It says, well, we've done really well. Here's our numbers between between a 2 and 2.5. Oh, wonderful. On the other hand, it doesn't really help us on a weekly basis. It's far more dynamic than this would suggest. Now, using analytics to identify improvement opportunities, the next step, you have to identify improvement opportunities, and you rank the opportunities, and you identify what's called the cost-benefit ratio for each opportunity. And that means you have to decide what effort you need to make the change and what the result's going to be. So is it great benefit, little effort, that's a great project. Great effort, great benefit, better, not a good project, but okay. Great effort, little benefit, not so good. Great effort, no benefit, not really a project. So there's 3 steps in identifying and selecting improvement opportunities. You have to determine the likely root causes of quality and performance problems, and that's the hard part. Defining the root cause, and we'll talk about that a little later. You identify possible countermeasures to address the root causes, and to estimate countermeasure impact and the effort to achieve goals. So you have to sort of start talking about how that works. Now, true quality improvement requires healthcare professionals to move beyond the who and what, the blame game, I call that. The blame game is, if you just made the secretary do this, it'd be a lot better. I love it, and to move on to the why and why that happens and what's happening and why it's happening, the defects and why waste occurs. Let me give you a great example. I was the COO for a quality improvement organization, and the printer would jam like 20 times a day. And people would go down to get there was one printer for each area, and the people would go down to get their printing processes, and it would be jammed, and they would yell at the secretary who was sitting there. And by the way, they went through 4 secretaries in about a year. Well, because they got yelled at for something they had no control over. And they kept yelling at her because it wouldn't work. And so we sat down and did a root cause analysis. Here's what's really interesting. So the organization, when you have a printer that's a high quantity printer, you used to be you had to change the rollers on a regular basis, but most people at organizations try to make them last longer because they aren't cheap. And so they would use the rollers for an extended period of time. The cause of paper jam was partly the rollers. The other thing is when you use certain printers, you have to use a certain quality of paper. The organization's CEO was cheap. And so he would buy really cheap paper, have him buy really cheap paper, and it would jam, so we'd waste half the paper. The third thing that would happen is you have to replace the toner in such a way that we had 2 different kinds of toner. One that you just buy as a unit, you just stick it in, and one that you refill yourself. And the refilled toners always have more errors in them. They cause more jamming because they don't conform to the manufacturer specifications. So we did a root cause analysis and found out that most of the causes were caused by the organization, and the secretary had no cause whatsoever. So we replaced the rollers. We started a schedule to replace the rollers. The secretary was responsible for the count of the rollers, and she had the authority to order a new roller when the paper count reached a certain level. We were no longer buying cheap paper and cheap toners, and guess what? Guess what happened? Of course you know, and that is that the jams went away. And so we kept our next secretary for several years, as a matter of fact, many years, because she wasn't getting yelled at for not something she had no control over. That's an important step. It's much easier and satisfying to yell at somebody when things go wrong, but it doesn't usually solve the problem. Fixing the problem is usually a system approach. And if you look at Deming and Giron, you'll find that they say that multiple times in their total quality management approach to quality improvement. It's usually a system problem. It's usually not a person problem. Isn't it interesting? 98% of the time, it's a system problem. So when you start blaming a person, you find that probably you're wrong. There are several alternatives for investigating root causes, and typically the categories are process, people, policy, materials, environment, and technology. Look at only one of these elements are people. All the others are really system problems. So let's look at what's called a fishbone diagram. We look at process, people, policy, materials, environment, technology, and we look at root causes. So we find out why we're having waste, and we start to identify each one of these areas, and this fishbone tells us what we need to fix to stop that error or that waste. And so this fishbone diagram is called. We can do another process called a Pareto chart. And a Pareto chart identifies how many times something happens. And so simple Pareto chart determines the important contributing factors to quality problems. And you see that we start to see this effect here. This, by the way, is the aggregate number, so we get this number out here. But the truth is we have too many clicks in the process in the software. And the triage override rule, there's too many clicks. So there's too many clicks to causes for that, too many clicks, and that's the problem. If we fix that, confused from design, we fix that, and then we start to see, but this fixing the clicks would really solve a lot of the problems, wouldn't it? So the cause of the override is really a system problem in the software, not that we had a bad nurse who was too lazy to do it differently, which is what people thought, which I find interesting. Always go to the people problem when it's only 2% of the root causes across the board. And lo and behold, it was a software problem that we could correct easily. We called the manufacturer. They changed it within days. It was amazing. Now, when you start estimating the impact and effort, some QI interventions can result in large impacts, but require relatively little effort to make the correction. These are great projects because you can make a great change with almost no effort, no money, no people, no man hours. People love it, and your CEO will think you're sent from heaven. Now, most QI opportunities have some variation between impact and cost and correlation. There's very few actually hit this one area. And determine where a project lies in the continuum, QI professionals use what's called an impact effort grid. And let's take a look at one of those. And that's this grid. So it's a sample, so it could be in either four quadrants. We'll start 1, 2, 3, and 4. If you have low impact and low effort, then you can consider this a low impact, low effort. Means we don't put much effort in, but we don't get much out of it. That's kind of a nice to do kind of thing, and you should consider it. If you have a high impact and low effort, you do those as fast as you can do them because they don't cost you much and they result in great change. If you have the high impact and the high effort, you evaluate those because they may be very important to you, but the cost is greater. It doesn't mean you do these, you don't do these over these, but these are the ones that are the low-hanging fruit, we call that. So if you're looking at low-hanging fruit in a tree, you tend to pick those first. And then low impact and high effort, you don't ever do those because the benefit is almost negligible compared to the money you have to spend. I remember when a new CFO came into our healthcare organization and decided that she wanted to change the logo or wanted to change our stationery. And she said, we're just going to change the stationery. So analytics did a look and see what that would cost us. In our organization, it was $350,000 because the old stationery was thrown away. The cost of resetting all the systems up to get the new stationery was going to cost some money, the setting fee, and then to get the new stationery. So it was really a $350,000 process. Obviously, she didn't get that. We stayed with the old system, and we didn't need to change. There was no reason to do that other than just personal bias, I guess. So estimating impact and effort, we said the quadrant 1 was low impact, low effort. You should consider that. Quadrant 2 was high impact, low effort. That's an immediate move. Quadrant 3 was high impact, high effort. That's you evaluate. And low impact, high effort, you try to stay away from those like the plague. Now, analytics in the project execution phase. During the execution phase, the quality teams require a lot more detailed data with what's called a rapid turnaround. So they want to see, is our improvement going? And they may need data daily or even more often than that. They may need real-time data, and sometimes you'll set things up so it measures that, creates a dashboard that changes as that data is managed. And that helps them make quick adjustments because, you know, what is it, all the plans of mice and men off go astray. And the truth is that what you think you're doing may be different. I remember a project I started in a clinic, one of the clinics I had, which was to improve we were doing a pilot project to improve revenue flow. And we set this up. We spent 2 months setting this thing up. And we got halfway through, and we got 2 days in actually, and realized that everything depended on this very specialized printer, which didn't work half the time. So this whole project was about to fail. So we got the team together and said, okay, we need a process that does not depend on this printer. This is way too much. We need to do something very different. And we set up a totally different process within about 2 hours. It was a great success, but we had failed that one time in the initial. So we spent 2 months putting it together in one way and 2 hours putting it together in a better way. Well, because we'd seen what doesn't work. And so sometimes you find in your pilots or your quality improvement project that what you thought was really going to be easy is really, really hard and not as doable as you think. So during this phase of quality, teams are more directed in the information they are seeking, and because workflows and processes are being changed, data needs to be more real time, and I can't emphasize that enough. The outputs for analytics in this execution phase should be relevant to the process or other change that is subject to the improvement effort. So it has to be important information that's relevant. It should be focused locally on that data. Don't give them a big gobbledygook of data, but data that's specific to what you're doing. It should be available in appropriate formats so QI members can evaluate both the variability of the data and the magnitude of the change in performance without doing their own analysis. And it should be, like I said before, it should be available in near real time to allow for rapid adjustments. Rapid quality improvement, RQI, is a type of quality improvement that really depends on this approach. Now, using analytics to evaluate outcomes and maintain sustainability, often QI projects are not sustained, and you've heard me say it lots of times, because the process reverts to the pre-change over time. And that's because there's no sustained evaluation and some put in the planning. So they stop doing the measurement. Once they get where they want, they just stop doing it, and people revert back to where they were. The metrics of the QI project should be sustained for weeks, months, sometimes years after the project has been complete to ensure it's sustainable. It's been sustained. And at a certain point where the data levels out and all of your results show that the changes, that everybody is transformed, then you can stop doing that, stop doing the measurement directly and start doing it more generically. And analytics should help establish those long-range post-project, and I call them post-mortem metrics. Post-mortem means after death, but post-mortem means after we've done the project, what are our metrics showing? And you keep doing that, and when I would have people do quality improvement projects, I would have them continue those metrics. We'd establish a death date, we call it, for the metrics, and that was the day when things would go away. And we'd have a conversation with that with the department and all that to ensure that those were continued and so that the people couldn't revert back to old processes. So we've completed Chapter 8. Thank you very much.